Welcome to UMDF's Ask the Mito Doc monthly webcast. Tonight, we'll kick off with Dr. Ha Tran from Astellas Pharma, who will share a little info on their current trial. We will then hear from Dr. Lucine Umbartsumyong from Seattle Children's Hospital, Seattle, Washington, about gastrointestinal issues in patients with mitochondrial disease. Our moderator this evening will be Margaret Moore, UMDF Support and Education Associate. Our Ask the Mito Doc webcasts are made possible through the generosity of sponsors, so we ask that you join us in thanking the Edith Trees Charitable Trust, Zogenix, and Astellas Pharma for their ongoing support. We are excited about Mitochondrial Medicine 2022, live in Phoenix, Arizona. Registration is open. Please visit umdf.org/symposium to check out the program and to register. The hotel group rate cutoff is May 5th. If you are 100% not attending and are holding a room, please release it for others this week. For the safety of our attendees, we are also requiring attendees to be fully vaccinated and wear masks within the meeting space. For those uncomfortable with traveling this summer, please remember that most sessions are recorded. In addition, we will provide an opportunity for you to participate in the Ask the Mito Doc panels virtually on Saturday, June 11th. Registration for those opportunities are also available at umdf.org/symposium. The UMDF has a coronavirus resource page, and we have recently included some safety tips for those considering travel to the symposium this summer. Visit www.umdf.org/symposium to check out our new travel guide. If you haven't visited our new patient registry page, MitoShare, please check it out at umdf.org/MitoShare today. This is a worldwide research database for patients with any form of mitochondrial disease. You do not need to have a confirmed diagnosis or Mito in order to join. Patients at any stage of their diagnostic journey are welcome and encouraged to register. Getting started is easy. Just click on New Account at umdf.org/MitoShare. You can share as little or as much as you want. Joining the platform helps the larger community, but it also features some wonderful tools that we think patients and caregivers will really appreciate. Spring is here. Join us and walk your way this spring safely. Find a walk location near you and walk your way at energyforlifewalk.org. We know you're seeking answers, and UMDF is always here to educate in difficult times and provide helpful resources and offer caring support. We can connect you with our patient concierge, or you can contact our support line at 888-900-6486, and our patient concierge representative will connect you with a local Mito family or a UMDF support ambassador from our national network of volunteers. Before we hear from our panel, we have some housekeeping items for you. We have muted the lines, so if during this webcast you have a question, please use the Q&A button to type in your question so that we can get answers for you. We ask that you keep your questions short for this webcast. We may not be able to answer questions that are too personal or detailed for this forum. Also, please note the information about the closed captioning at the bottom of your screen. Looking ahead, next month we will hear from Dr. Amy Goldstein and Dr. Sonal Sharma from Children's Hospital in Philadelphia. For those needing a refresher or those newly diagnosed, they will be providing a basics talk about mitochondrial disease. Watch your email and social media for ways to register and to submit your questions. Now let's get started with Dr. Ha Tran and Dr. A.
Hi, everybody. This is Beth Whitehouse. I am standing in for Margaret Moore, who unfortunately is a little bit under the weather. So I welcome you all tonight and turn it over to Dr. Tran from Astellas Pharma. Dr. Tran?
Thank you so much, Beth, and thank you to UMDF for allowing us to be sponsors and have us here today. So a brief introduction, I am Ha Tran. I'm a board certified pediatrician. I still practice medicine on the adjunct faculty at Stanford University out in Palo Alto, California. And I am the Senior Medical Director at Astellas Pharma, and I've been working in rare diseases for about 8 years now, running clinical trials in the rare disease space. So with that, I want to share my screen and just to give you a quick overview of our ongoing clinical trial. I know you really want to hear about gastrointestinal manifestations, so I will keep it brief. Okay, are you able to see my screen, Beth? Just making sure.
Yes, we're good.
Yes.
Thank you.
Okay, thank you. Okay, so I just wanted to give you a brief overview of our ongoing study, which you may potentially be able to participate in. It's a phase 2 to 3 study evaluating safety, tolerability, and efficacy of our molecule ASP0367 in participants with primary mitochondrial myopathy. So just a disclaimer that what we are discussing today is not promotional. The drug is under study and under clinical investigation, and we have yet to establish any efficacy or safety data. And it's not approved and it's not available commercially. So about Astellas, we are a mid-sized pharma company. We are located, the headquarters is in Tokyo, Japan, but there's also a North America office in Northbrook, Illinois. I'm one of the fortunate ones that am allowed to work remotely. So I'm based out in California, and we actually have a global team. So we have employees all across the globe. ASP0367 is again, it's investigational. It's an oral daily tablet. So you take it once, the participants take it once a day, and we're investigating it for treatment of muscle weakness, fatigue, exercise intolerance in patients with mitochondrial myopathies. It is a new class of something called a PPAR delta modulator. And I'll give you a little bit additional information. So it stands for peroxisome proliferator activated receptors. And there are 3 different isoforms, alpha, gamma, and delta. And they are receptors on the nucleus, and they act as transcription factors to control a wide range of different processes in your body that regulate gene expression. So in preclinical models, it has been shown to improve fatty acid metabolism and mitochondrial biogenesis, which in turn hopefully improves muscle function. So currently we have 2 ongoing clinical studies with ASP0367 targeting 2 myopathies. So there's one study ongoing in it's a phase 1b study in patients with Duchenne muscular dystrophy, and this is targeting boys ages 6 to 16. And then secondly, we have an ongoing phase 2 to 3, it's a seamless phase 2 to 3 study in primary mitochondrial myopathy. So this is a randomized, double-blind, placebo-controlled clinical trial with a target total of 175 participants, ages 8 to 80, with primary mitochondrial myopathy. The primary purpose is to select a biologically active dose based on PK and PD evaluation. So that's the phase 2 portion, which consists of approximately 30 patients. And then the next phase is phase 3. Once we select a dose, we'll go on to phase 3, and that assesses the effect of the study drug on functional improvement compared to placebo. And additionally, the intention of the study is to evaluate safety and tolerability of the molecule as well. We have approximately 15 sites across the U.S. We do have additional information on clinicaltrials.gov. There's also an Astellas website that'll take you there. And the QR code is actually very small here. We've forwarded the slides to UMDF, so if you'd like additional information, I believe they'd be happy to share it with you. So I'm just going to briefly go through the phase 2 portion. The study is currently in phase 2, recruiting the first 30 participants. So there's a 4-week screening period, and then where the study participant is randomized to either a low dose, high dose, or placebo. So they're in this phase for about 2 weeks, and then they will continue on their phase 2 dose for 50 weeks. after which time all patients actually move to open label extension and receive the active study drug. And then there's a 4-week follow-up period. Once the phase 2 portion completes, the remaining 145 participants will go into the phase 3, which is the selected dose based on the phase 2 data. There's a 4-week screening period, and patients are randomized 1-to-1, either to the active study drug or placebo, after which, after 52 weeks, they're allowed to convert to active study drug for 6 months, so 24 weeks, and then there's a 4-week follow-up period. In regards to like who can participate, this is obviously high level, but they're targeting adult patients, ages 18 to 80, have a confirmed diagnosis of primary mitochondrial myopathy by genetic testing, and then also need to be able to adhere to some of the study requirements, such as being able to walk for 6 minutes, and then also the ability to use some of the applications that we have for our other measurements, such as there's some video recording and digital apps. We are excluding patients with other symptoms that are not related to PMM or who make it difficult to use. For example, if participants unable to walk or to sit and stand for certain parts of the study, unfortunately will have to be excluded. Any acute illnesses or other conditions that would not enable the participant to be fully engaged, such as mental health conditions that would not allow them to participate, or behavioral issues that would not allow the participant to complete the different study assessments. And then any unstable cardiopulmonary conditions, heart problems, severe scoliosis, if the participant requires 24/7 ventilator support, or any kidney or liver problems that wouldn't allow to screen. So again, that was very high level overview, but if you would like additional information, we do have a QR code, we have a website. UMDF also has linked Astellas clinical trials on their website, and then we also have direct website or phone number, and I'd be happy to follow up with any questions in the Q&A. And with that, I just want to thank you very much and pass it back.
Wonderful. Thank you, Dr. Tran. And as Dr. Tran mentioned, if you have any questions related to the Astellas trial, please do put those into the Q&A, and she will be able to address those this evening, or we can pass them on following the meeting. So thank you. I'm now going to turn it over to Dr. Ambart Sumyan. Hopefully I didn't murder your name. I apologize. To join us and to make sure that you are unmuted, and welcome.
Thank you, Beth. First, I would like to thank the UMDF organizers for allowing me and giving me the opportunity to be here. And most importantly, I would like to thank all the parents and the patients who've taken their time from their busy schedules to be here and participate and be with us. Today's talk is going to be on gastrointestinal manifestations of mitochondrial disease. Just a little bit about me. I'm an associate professor of pediatrics at University of Washington, and I'm the director of gastrointestinal motility program here. I am involved with our neurology department here in caring and partnering in the care of mitochondrial disease patients and or patients who have an overlap between motility and mitochondrial disease. Our objectives are to understand the role of gastrointestinal disorders in pediatric mitochondrial diseases, to describe the approach to a patient with mitochondrial disease and suspected GI disorder, and to review the evaluation and management of patients, and especially a child with a mitochondrial disease. As you are all very well aware, the mitochondrial diseases have a myriad of organ involvements. They can affect anywhere from neurological to ocular, cardiac, renal, endocrine, musculoskeletal, neurological, and also gastrointestinal. And it truly can affect anywhere from your mouth all the way to the anus. It could give you trouble speaking. You can have dysphagia, trouble swallowing, trouble with your esophagus, trouble with your stomach, the small intestine, and the colon. And today we're going to look more specifically at these different organ systems and how mitochondrial disorders can present via GI manifestations. Here are just some examples of specific mitochondrial diseases that are known to affect specific GI organs. For example, patients with Leigh syndrome and Kearns-Sayre syndrome can have oropharyngeal abnormalities and specifically esophageal dysmotility. There are specific mitochondrial hepatopathies, meaning that there's specific mutations that can give you liver disease. Patients with Minji syndrome or Mella syndrome classically can develop chronic intestinal pseudo-obstruction. Patients with Leigh syndrome, Minji, and Mellas can develop gastroparesis. Others may develop diarrhea due to pancreatic insufficiency or enteropathy or other specific type of encephalopathies. They can develop diarrhea. So it really is important for the gastroenterologist to really understand the type of if there is an identified mutation, to know the identified mutation in order to help the patient. The goals of patient care revolve around quality of life, and it's important to control the symptoms. We know that not always can we cure the symptoms, but we can control them. We can optimize nutrition and hydration, only utilize appropriate testing if indicated, all centering around quality of life. And I say appropriate testing when indicated because we understand that in patients with mitochondrial disease, you don't just want to do any testing that is available, especially testing that involves the use of an anesthetic. And most commonly in GI procedures, we do use anesthetics. Knowing that patients with mitochondrial disorders need specific anesthesiologists, have a very, very specific response to an anesthetic, we're very judicious about the use of testing. So what do we know about GI symptoms in patients with mitochondrial disorders? I was telling our organizers in the beginning of this talk that I gave this similar talk in 2016, and most recently when I was invited to give the talk again, I actually did a literature search just through our big database about what new information do we have from 2016. And I, in general, do this frequently, but I just wanted to do a more comprehensive review. And the most deflating and sad part was that actually not one good study was identified. And that is very disheartening because this is a very common problem affecting the quality of life of so many patients, and yet we are devoid of studies and of essentially ways of helping our patients. It just highlights the need for more robust involvement. GI diseases symptoms are common in up to 15% of adults and up to even 60% of pediatric patients. There's increased frequency in specific mitochondrial diseases with specific gene mutations. For example, patients with Minji, greater than 50% will have GI symptoms, and actually 100% of them will develop GI symptoms during their disease course. Those with M3243A, greater than gene mutation carriers, can have up to 90% of them can have greater than one GI symptoms. And those with maternally inherited diabetes deafness, 88% of them have been reported to have either constipation and or diarrhea. A Dutch study actually took patients who have the M3243A mutation and compared them to patients who have no health problems and wanted to see these regular things that we all experience: flatulence, bloating, constipation, abdominal pain. Are they really more common in mitochondrial patients? And what they showed was that they are actually more common. Children with mitochondrial diseases have increased frequency of these common GI disorders. And the presentation is non-specific, and there's a wide spectrum of presentation. And patients can present with gastroesophageal reflux and abdominal pain and constipation, to more serious of nausea, vomiting, weight loss, malnutrition, dysphagia, gagging, and dependence on gastrostomy feeds, gastrojejunostomy feeds, and in very severe cases, even on parenteral nutrition, which is where they get nutrition through the IV. And there aren't very many studies, but the ones we do have in pediatrics highlight that GI symptoms are common, greater than 56% in this one study, and most of them do present as failure to thrive. In this population, in this one study, 14 of the 36 patients had failure to thrive and required G-tube placements. As you can see, some of them had pseudo-obstruction or cyclic vomiting, diarrhea, liver dysfunction. In a different study, the GI symptoms were less. It was 8%. But of those, half of those patients had failure to thrive. And it was the presenting symptom in 10%. Again, 60% nearly required G-tubes and some form of nutritional supplementation. And 4% had dysmotility and required jejunostomies and, again, nutrition through the IV or parenteral nutrition. So failure to thrive is a common theme. So nutrition, hydration, all the things that compromise nutrition and hydration are very important to take into account. So we're actually going to go through in a systematic way from mouth all the way to the anus. So we're going to start with the upper part. Patients can have trouble swallowing, or also known as dysphagia, can present in up to 45%, and it usually starts out with solids and can slowly progress to liquids. And what's interesting is that when I send my patients to have an esophagram, which is this, they drink something and then the contrast passes through the esophagus, and then the nuclear, and then the fluoroscopist takes x-rays. And that's kind of how I know how things are passing through the esophagus. Most of my patients actually have more trouble as the day progresses. So I usually have them book the appointment at the end of the day versus first thing in the morning. A lot of our patients have difficulty with liquids. As I said, the weakness can progress throughout the day, and this can actually predispose them to aspiration, which is where you're eating and drinking, but it actually, instead of going to the esophagus, it goes into the trachea and into the lungs. A lot of patients also may have dysphonia or dysarthria, which is when they're speaking, their voice quality can change, and also they have trouble speaking. And usually when I ask my patients, well, does your child have trouble speaking by the end of the day, or do they have trouble with their voice by the end of the day? That's a sign for me that perhaps their dysphagia or the trouble swallowing can also have similar type of progression. Other patients can have oropharyngeal discoordination, which is where your oropharynx is not coordinated, and that in itself can predispose you to aspiration, commonly seen in patients with Leigh syndrome. Other patients, such as Karen-Sayre syndrome, can present with cricopharyngeal achalasia, and that's where your upper esophageal sphincter, that's where the food can go from your mouth to the esophagus, does not open very well. And others can actually present with esophageal dysmotility, or where your esophagus is not moving properly. So they can have absent peristalsis, which is the movement, or trouble with the actual sphincters of the esophagus moving. And that in itself can give them sensation of food being stuck in the esophagus, or even vomiting or reflux symptoms. And how do we evaluate some of our patients who present with abnormal esophagus or oropharyngeal function? I always like to have my patients been evaluated by speech and language therapy. It's very important that they have a video fluoroscopic swallow study, because that can tell me how is their coordination. Are they at risk of aspiration or not? And then for the esophagus, I like for them to complete an esophagram if they can, where they swallow the radiopaque substance, and then they take films, and I can see how quickly things pass through the esophagus, if there's any anatomical problems. And then lastly, if indicated, I would do esophageal manometry, where I place a catheter through their nose into the stomach, and I measure how the esophagus is moving, and try to correlate their symptoms of dysphagia, their symptoms of globus, meaning that they feel the food is getting stuck in the esophagus. Would that be related to their esophagus moving or not? And treatment, of course, is speech and language therapy, feeding therapy, implementing specific precautions or restrictions of food, depending on the finding of the tests. Now let's move towards the stomach and the small intestine. Trouble with the stomach can present in so many different ways. And in this study, actually, when they looked at gastric and small intestinal presentation of patients with mitochondrial disease, they can have nausea, vomiting, abdominal pain, this feeling of fullness where the child says, oh, I'm really hungry and I really want to eat, but after a few bites, they just feel bloated and feel very full. That's also called early satiety and or weight loss. Problems with the stomach can be of different etiologies or causes. You can have a problem with abnormal gastric accommodation, meaning that when I smell French fries, my stomach will open up and accept the French fries. So this acceptance of the stomach of food is called accommodation. It's accommodating to the food. But some patients may have trouble with accommodation. That's if they have symptoms within an hour of eating, or what we call early satiety, or getting full too easily. Or you can have actually rapid gastric emptying. So there's patients where the food actually empties through the stomach too quickly. Or patients can have delayed gastric emptying. And the difficulty is that the symptoms of rapid gastric emptying and the delayed gastric emptying are very, very similar: nausea and vomiting. But gastroparesis, or nausea, vomiting, abdominal pain, in conjunction with delay in gastric emptying, are pretty common in patients with mitochondrial disorder. There's one of the studies here that showed that almost 70% of patients with mitochondrial disease had a delay in gastric emptying. And the difficulty here lies that we use medications called prokinetics, such as erythromycin or azithromycin, in order to stimulate the stomach to move. But our patients with mitochondrial disease have not proven to be very good in terms of responding to these medications. And we also know that working with our mitochondrial specialists, that erythromycin is not very much liked by the mitochondria. And that in itself could be problematic. So I always obtain permission from our mitochondrial experts. I work closely here with Dr. Sinedo in order to start patients on erythromycin. And we also know that in large pediatric studies, there's 8% of pediatric patients who present with gastroparesis may also have a concomitant mitochondrial disease. And these patients, if they have a mitochondrial disease, are usually the ones who have poor outcomes, meaning that they don't respond to our medication. It takes much longer for us to get resolution of symptoms. So how do we test for gastric emptying? So it's very important that you're in a good center that uses national guidelines and does a gastric emptying study, meaning that you ingest a very specific meal and sequential films are taken at 1, 2, and 4 hours to tell the stomach and measures how quickly things empty from the stomach. So we have specific guidelines for rapid gastric emptying, and we have specific guidelines for delayed gastric emptying. But the frustration here lies in the fact that these numbers are based on adult data, because we can't ethically take healthy patients, pediatric patients, and expose them to radiation. So again, we are limited. So what can you do for delaying gastric emptying? Small, frequent meals are what's recommended. We recommend low fat, low residue, or low fiber meals. We want to limit the FODMAPs, which is your oligodisaccharidases and some of the specific sugars in the foods. Usually liquid is much better tolerated than solids. So trying to do liquid supplementation with Boost or Kate Farms or any of the liquid nutrient forms is recommended. And for some of our patients, for a period of time, we have to have pureed foods or blenderized feeds. These have shown to be improvement. And for others, we use ginger or peppermint oil. Peppermint oil actually will relax the stomach, and ginger has ability to accelerate the stomach. So what medications can we use to improve the empty? Again, erythromycin, but permission with the neurologist. Azithromycin, which is better tolerated sometimes, but not as efficacious. We can use Reglan. It's great, right? Metoclopramide, Reglan, because it works for nausea and really can help with the gastric emptying. But the problem is there's a black box warning, and you can't use it for more than 3 months because 1% of patients can develop permanent, essentially permanent fasciculations of their tongue. And there's much more fancier medications, domperidone, which is a sister medication of Reglan, which doesn't go to your brain and doesn't give you those side effects. But domperidone and cisapride, which work wonders, are not FDA approved in pediatrics in the United States because they can give you prolongation of the QT and sudden cardiac death. So cisapride is available in certain centers under specific clause and under very important you have to actually participate in the study to get cisapride. And domperidone, some of the families do purchase them from Canada or Mexico. But again, it has to be in a specific center and heavily monitored by EKGs and also with the help of a gastroenterologist and a cardiologist. And what medications can improve the gastric accommodation? So we use cyproheptadine. I'm a fan of cyproheptadine with low side effect profile. We can use that in younger kids, improves appetite. For the older kids, we can use mirtazapine or buspirone, but these medications are also can be used for specifically for depression and anxiety, just because the serotonin receptors that they work on are also found in your gut too. So I like to use them in conjunction with a psychologist and a psychiatrist to make sure that there's no concomitant depression or anxiety in the patient. Some non-pharmacological treatments, especially if the pharmacological ones have failed, would be pyloric balloon distension. I am not a fan of this, specifically in my patients with mitochondrial diseases or the intrapyloric Botox injections. It's because the way I look at and some of these treatments where they actually cause damage to the pylorus or relax the pylorus is that when you open the floodgates between the stomach and the small intestine, you allow for small intestinal bile to go back up into the stomach. And if the patient has small intestinal dysmotility, now you've opened up the floodgates for the food and other secretions to go from the small intestine to the stomach. So I'm extremely cautious, and I really don't like to use some of these treatments in patients, specifically if I suspect small intestinal dysmotility. Gastric electrical stimulation has not really been studied specifically in patients with mitochondrial disease. It's been studied in patients with more functional diseases. While it does help with symptoms, no one has really been able to prove that it helps with the gastric emptying. And lastly, of course, when a patient is unable to meet their hydration and nutrition through a G-tube, which is a gastrostomy tube, then we extend that tube to the small intestine, also known as a gastrojejunostomy tube, where we can vent the stomach through the G portion and feed the patient through the J portion. What things can go wrong, right, with the small intestine? So I did mention in my previous slide that I worry about small intestinal dysmotility, and that's because that's a real thing, and it can really happen with patients with mitochondrial disease. Some patients can have villus atrophy, which is where the small little projections in the small intestine can actually atrophy and not absorb the food. In some patients, their pancreas doesn't work very well. And when your pancreas doesn't work very well, and your villi, which absorb your nutrients, don't work very well, then you're going to have diarrhea and malnutrition. In other patients, actually, they get significant distension and bloating because their intestines are actually not moving very well. So these patients where they have small intestinal dysmotility, also known as pediatric intestinal pseudoobstruction, also known as chronic intestinal pseudoobstruction, when the intestines don't move, the bacteria stay, multiply, and you can have small intestinal bacterial overgrowth, malnutrition, and distension and bloating. So how do we actually diagnose someone with pediatric intestinal pseudoobstruction? That is, the PIPO is essentially a symptom. You have these recurrent or these continuous symptoms of what look like true obstruction, where everybody, when they look at the radiographs, when they look at the patient, when they get the history, they're like, oh my goodness, this looks like a small bowel obstruction. But in reality, there's no mechanical obstruction. And when we have these recurrent symptoms of this or chronicity that develops, then we start to worry, is there a nerve problem? Is there a muscle problem? Or is it a mix of the two? And we do have some fancy ways of being able to diagnose this manometrically, but it is quite invasive. And then we would have to put a tube in the nose or in the stomach that goes into the small intestine. And then you stimulate the stomach and the small intestine to be able to see how they work, and you can differentiate the nerve versus the muscle function. Again, in the appropriate clinical setting, if it's going to change management, then that is indicated. So in adult patients, approximately 20% of them who presented with chronic intestinal pseudoobstruction had mitochondrial disease, and 50% of those presented with GI disease. And they have increased malnutrition, and they also have poor prognosis compared to patients who don't have mitochondrial disease. In pediatrics, sometimes the GI symptoms of pseudoobstruction can precede the neurological symptoms. And this one's shown in 6 patients in this specific study. These patients fail to respond to therapy. There's this progression worsening of their symptoms. And there's constant escalation of medical therapy, gastrostomy, jejunostomy, gastrojejunostomy, and parenteral nutrition. Usually when we're at a GJ tube or are advancing from a GJ tube to TPN is where I consider more advanced testing. Also, there are specific mitochondrial diseases that are associated with intestinal pseudoobstruction. Classically, these are your mitochondrial neurogastrointestinal encephalomyopathy, or MNG. Also, your mitochondrial encephalopathy, lactic acidosis and stroke episode, MELAS, Alpers-Hatter-Locker syndrome, myoclonus epilepsy associated with ragged red fibers, or MRF, and maternally inherited diabetes deafness. And these patients, if they present to clinic, then I kind of have an idea that at some point in time, they're going to progress to intestinal pseudoobstruction. And I don't necessarily need to do testing to be able to get there. Usually the radiographic studies and historical progression will give me that answer. Again, judicious about the testing because it requires significant anesthesia, and risk and benefits ratio always have to be taken into account. And lastly, with regards to the constipation, with regards to the bottom or the hindgut abnormalities, patients can present with diarrhea, or they can present with constipation and or with incontinence. So incontinence can be part of the constipation where they have significant stool loading, and because of this, they can have leaking of stool around this big stool ball. Or they can have incontinence because they have central nervous system or neurological abnormalities, or spinal anomalies, or neuropathy or abnormality of their anal rectum. So patients can have abnormal sensation, pelvic floor dysfunction, neuropathy of their anal rectum. Other patients can have a very slow colon, and yet others can have a colon that doesn't move very well, or colonic dysmotility. That could be segmental, part of the colon, or it could involve the entire colon. And it could involve the nerves or the muscles, or it could involve both. And how do we treat our patients? And the treatment must be very individualized. And it just depends, what are the goals of the treatment? And what is the family goal? What is the quality of life goal? So I have patients where if they're wheelchair bound and they're unable to sit on the toilet, and they're having incontinence because of constipation, and these stools are unpredictable, then the focus is on about predictable bowel movements, social continence, and independence. And how do we get to predictable bowel movements? Depending on the patient, can they sit on the toilet or can they not? I may use oral laxatives, right? I may use Miralax, lactulose, or milk of magnesia. Sometimes I can use Dopusate. But in patients where I really need to get the stool out, meaning that I need to give them the colon the oomph to get the stool out, I will use Senna, and I will be aggressive and use bisacodyl. And yet in patients where I really need predictability, like some patients will develop bed sores, or they have ulcers, or recurrent urinary tract infections because of the diaper and constantly being incontinent, I don't shy away from using suppositories or enemas, because I really need to get predictable bowel movements and give the patient and the family quality of life for them to be able to leave the house and do fun activities with their family members and their siblings as well. And we have very different ways and all these fancy ways of measuring things. And if I want to know if the colon is slow or fast, I give this little marker they swallow. I take an x-ray 5 days later. And if all the markers are in the rectum, then I know that, due to neurodevelopmental problems or patient refusal, they're having pelvic floor dysfunction and they're just not emptying. So I may tailor the treatment one way. If I see the markers distributed evenly through the colon, then I know that that colon is moving slowly, and I tailor the treatment in a different way, where I'm increasing the transit. Or maybe all the markers are gone and the patient doesn't even have constipation, but because they have developmental delay, they don't know when they have to go. Or maybe they have ADHD or other sensory dysfunction, and they just don't know that they have to poop. And in those patients, instead of giving them all these laxatives and stimulants, I may encourage the family to try suppositories on a daily basis to encourage and facilitate potty training, and to also give them the predictability that they need. In rare patients, depending on the age of the patient and what their symptoms are, I may do further testing. This is a non-invasive test that I may do where I inflate a balloon, I place a small balloon when the patient is awake, or at most I may give them Versed to make them a little sleepy. I place a little catheter in the rectum, inflate the balloon, and I test to see how the nerves and the muscles are working. I may ask the patient to squeeze or to push. And this is a very simple way for me to understand the function of the anal rectum. There's also more complicated ways for me to do this too, where I may place a catheter or a big tube inside the colon and can even tell the patient what part of the colon works or doesn't work. Again, I would only put someone under anesthesia if truly that test was going to change their management. So in summary, mitochondrial diseases significantly impact the GI system. The GI manifestations of mitochondrial disease are common and do impact quality of life. GI disorders in patients with mitochondrial disease are wide spectrum of diseases and have an effect on morbidity and mortality for our patients. An evaluation may require testing in the appropriate setting, and the goals of patient care are symptom management, optimization of nutrition to maximize quality of life and to decrease morbidity and mortality. Thank you, and I'm open to questions.
Wonderful. Thank you, Dr. A. We do have quite a few questions. We have about 10 that were pre-submitted prior to tonight's presentation and 12 in the Q&A section. So I just want to share with everybody on the presentation tonight, please don't get upset if we do not get to your question this evening. We will get you an answer post-meeting. So without further ado, I will get to the very first question. The first one is, for patients with primary mitochondrial disease and GI manifestations of nausea and pain, do you see an association with mast cell activation syndrome?
That is an excellent question. And I don't think anybody has the answer to this because nobody has really studied it. Mast cell activation syndrome is a bit of a newer thing, and we don't really understand too much of it, but it's not uncommon for mast cell activation syndrome, for POTS, or other functional diseases to be grouped the same. What I warn families is that a lot of the times we as doctors like to group patients in categories. And just because we have a category or keep adding categories doesn't necessarily change the medical management of them. So I just want to be careful of that, because if you keep adding categories such as mast activating or POTS, or keep the labels themselves, it may prevent people from like thinking outside the box as to what could be the other common things that could cause nausea and pain, and that may have them miss the diagnosis. For this specific patient, if a patient of mine has vomit, has pain, I separate that and I say that is a sensory dysfunction that may have other triggers to it. Then I go through a systematic process and I ask, so then we have nausea. What could be some of the triggers of the nausea? And is that activating the pain? Do we need to treat the motor and then treat the sensory in a different manner? So I always think of motility as motor and sensory, pain being sensory, and I always involve our pain doctors. And then I treat the motor, trying to take away the triggers that can affect the sensory. But sometimes you just need a pain specialist to be able to help you with neuromodulation to help with the sensory.
Thank you. The next question that we have is a live one. Is intestinal dysmotility in mitochondrial disease treated any differently than intestinal dysmotility in any other patients?
That's actually a really great question. It's treated about the same. The way, it just depends who you're asking. So what I do is, if a patient of mine has mitochondrial disease, then I heavily involve the neurologist. Like, I do not make any movements without our mitochondrial specialist. So here's the key differences. So I like to do erythromycin, right? I like to add erythromycin, which is a prokinetic mixed systemic move. So in a patient without mitochondrial disease, I'm extremely aggressive and will add them erythromycin and go at very high dosages. In a patient with mitochondrial disease, I will consult our neurologist and ask, do you give me permission to do it in this specific patient? And they may say yes, depending on their mutation, or they may say no. And if they say yes, then we're all extremely anxious and we are carefully monitoring for more of a side effect or worsening of their underlying mitochondrial disorder. Also, in a patient with mitochondrial disorder, you can have other comorbidities. So if you already have prolonged QT, then it's going to be extremely difficult for me to add erythromycin, especially in conjunction to Zofran, which work together prolonging the QT, or even try other investigational medications, because if I'm already using a non-FDA medication on a patient who doesn't have mitochondrial disease, it makes us much more nervous to use it in a patient with mitochondrial disease. But otherwise, in terms of if the patient has pseudo-obstruction, most of our patients have a G tube, a GJ tube, or they have an ostomy. So the surgical management is about the same. Some believe that if you have mitochondrial disease, your outcomes with intestinal transplant are also lower, or you may not have as much success with an intestinal transplant. So in general, I always think of the prognosis a bit more guarded with someone with mitochondrial disorder versus someone who doesn't have it. And that just may be that when we don't know when someone doesn't have a mitochondrial disorder, we just don't know what's causing their issue. And then we are blinded, and that's kind of like an abnormal bias. I hope that answers the question.
I hope so too. And if not, please, Stephanie, type your additional question for us. The next one that I'm going to share is from Shelley. What might be an indicator if I experience bloating and weight gain around the stomach and neck? No bowel issues currently.
Weight gain or weight loss?
It says weight gain.
Bloating and weight gain. Mm-hmm. So if somebody experiences weight gain, then my suspicion for an underlying GI immotility or a GI disease is very, 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 very low. Because if your esophagus doesn't work, or your stomach doesn't work, or especially if your small intestine does not work, you're not going to absorb nutrients, so you're going to be losing weight. So in that scenario, I would look for other causes for that, especially like Cushing syndrome or other endocrinopathies or other causes that would give you those symptoms, and not primary intestinal problems.
Jenny asks, for someone with dysphonia, whoops, I'm sorry, it just jumped right for me. For somebody with dysphonia and glottic insufficiency, have you seen benefit with vocal fold augmentation? Speech therapy is already being implemented, but some days are still worse than others.
Mm-hmm. And I'm assuming when they mean vocal fold augmentations, they mean that the injections that some centers do. I'm assuming that's what they mean. That is more of our ear, nose, and throat, or the otolaryngologist. Specifically, that has been shown for patients who have dysphagia, not necessarily because they have trouble with regards to dysphonia. So it's hard for me to answer the dysphonia part of it, but what I can say is that for some patients where they have dysphagia and nobody really knows what the cause of the dysphagia is, then they can go in intraepiglottic injections, and that has been shown to be of some benefit. But that is a good question for ENT doctors.
Thank you. Let's see here. For the erythromycin and azithromycin, how do you counteract the gut issues that often arise from long-term use of antibiotics?
Mm-hmm. That is an excellent question. So the thing with the erythromycin specifically is that we are using it at a lower dose that is not a true antibacterial dose. Actually, if you try to use it at very high dosages, then you may have adverse effects of more nausea and vomit. So we use it at 3 or 5 milligrams per kilogram 3 times a day, or I use it at most up to 10. In reality, we actually do not know what the long-term effects are of using antibiotics, in terms of years and years, and what it does in terms of dysbiosis to your gut flora. But what I do know is that I don't have any other option or any other drugs. If I had domperidone and cisapride and many other things at my disposal, then perhaps I won't use erythromycin or azithromycin. But at that point in time, if the decision is between doing a G tube and a GJ tube, we want to use the medication. If it's between GJ tube and TPN, then I am going to use the medication, because we literally do not have any other option. And so that's why I say we do the testing when indicated. Like, we will do the gastric emptying study. If it's abnormal, then place someone on erythromycin, and not just blindly place them on antibiotics.
A question from Eric. Can chronic thrush indicate bacterial overgrowth?
That's a great question. Chronic thrush, I don't necessarily think that it indicates small intestinal bacterial overgrowth. That has not been particularly associated with it. Now, if somebody had, candida in their esophagus, that would be a different thing. Then I may be worried that the esophagus is not moving. But if it's thrush just on the tongue, I don't necessarily suspect bacterial overgrowth, no.
Shelley asks, what would be the best treatment if prokinetics are less effective?
Okay, and so in terms of making the stomach, the prokinetics we can refer to as making the stomach move. So if we're using prokinetics to make the stomach move and they are not effective, then we actually have to then bypass the stomach by doing the GJ tube.
Barbara asks, our daughter with mitochondrial disease developed a GIST in her early 30s. Is there a relationship between the two conditions?
Not to my knowledge that there's a relationship between the two conditions. I think the GIST, gastrointestinal stromal tumor, that could be like genetic, or it could be just de novo mutations, depending on the type of gastrointestinal stromal tumor and where it was. But to my knowledge, that there's not a direct correlation between mitochondrial disease and the GIST tumor.
Thank you. Crystal asks, how do you test for and treat pancreatic insufficiency?
That's a great question. So patients with mitochondrial disease develop pancreatic exocrine insufficiency. And it's like endocrine insufficiency would be that your pancreas makes insulin so you can become diabetic. Exocrine would be that it makes these specific enzymes, and that's how you digest fat. So you present with bloating and diarrhea, and actually the way you test for is you test for stool fecal elastase. That's how you would test for it. So it's a stool test.
Right, thank you. Stephanie asks, are large numbers of food intolerances common in mitochondrial disease? Is there any treatment besides avoidance, especially when the foods tolerated are few?
Mm-hmm. It all depends on exactly the cause of the intolerance. So if somebody, for example, has oropharyngeal dysphagia and they're only tolerating purees because the thin liquids are causing them aspiration, then we don't have very many options. We have to stick to the guidelines of what the feeding therapist is saying. If somebody has esophageal dysmotility and they get tired throughout the day, and the more they eat solids throughout the day become a problem, then of course we go by what is most tolerated. If the patient has gastric delay or gastroparesis and they're not tolerating fatty foods, then yes, we try to avoid those and do low residue, low fat, carbohydrate-based, liquid-based diets. With regards to an intolerance where it's presumed to be an allergy, those are very difficult to actually diagnose. I always tell my patients, it just depends what your intolerance is. If your intolerance is that you will develop distension and pain and discomfort, at some point you would have to kind of come into terms of, am I willing to have these symptoms for a 24-hour period or 12-hour period or not? But so for this specific, it just depends on what an intolerance is. Sometimes they're diagnosed, sometimes these intolerances are not diagnosed, and ideally, we want to be able to know the cause of some of these intolerances, because if there's a true cause that could be fixed, then that's great. But if there isn't, and you're becoming more and more and more limited, we have to weigh the symptoms. Is it sensory or motor that's leading to these intolerances? Or is it truly like the motor is the predominant aspect of it and we have to treat it? So that's like a fully loaded question. At the risk of benefit of going to a GJ, a G, or how do you eat and what the intolerances are going to be the key.
I'm going to move over to one of the pre-submitted questions now. What do you do when you don't tolerate your PEG feeds in the hospital, for example, vomiting for a period of time? What should be done nutritionally to avoid decompensations?
Mm-hmm. And just to clarify, you said PEG, like PEG
yes.
tube feeds? Okay.
PEG, yep.
PEG. Mm-hmm. So And this is very common, right? Like the patient has TNA. Like I have a patient with mitochondrial disease that he had a TNA, and then for like a week he was unable to tolerate his gastric feeds. And a PEG tube is essentially it's a gastric tube. And what I usually tell the families is, if you're getting bolus feeds and you're not tolerating your bolus feeds, then let's take a step back. Let's do continuous feeds. If you're not tolerating your continuous feeds, and now we are hitting at a nutritional compromise, then for a period of time, I will advance the gastric feeds of the pig to a GJ tube feed and feed post-pylorically, meaning into the small intestine. And after a while, once we have recovery, then I will slowly transition them back to the stomach. But that would be a tricky case where I would refrain from putting in a central line or TPN, and I would try to use the intestine as much as possible, even if it requires bypassing the stomach.
Another pre-submitted question from Jenny. What suggestions, options do you recommend for someone in stage 4 liver disease with a primary mitochondrial disease, complex 1 deficiency?
I'm sorry, can you just repeat that question one more time?
I absolutely will. What suggestions, options do you recommend for someone in stage 4 liver disease with primary mitochondrial disease, which is complex 1 deficiency?
So I honestly am not qualified to answer that question because I'm not a hepatologist. But what I would say is that if you have concomitant liver disease, then seeing a hepatologist is going to be your go-to person. Because a motility specialist or a regular GI, we have specifically board certification, so we don't commonly see hepatologists. But being at a big center with a big hepatology team where they are a primary also mitochondrial center is going to be the key.
Great, thank you.
Because sometimes those patients get listed for transplants too. So we have patients with mitochondrial disease, with end-stage liver disease who get liver transplants. That's why being at a big center with those options is going to be key.
Okay, great. Ariel asks, my 4-year-old daughter, FARS2, has history of failure to thrive, elevated liver enzymes, and hardening of liver. Currently, liver enzymes and liver are stable. Starting late December, she started experiencing diarrhea and has not had a formed stool since then. She also experiences, from what we can tell, she's nonverbal, frequent uncomfortable flatulence and bloating. Only notable blood work shows pancreatic FX less than 200 function, 103, then 124 over the last 4 months. Cause unknown without knowing how to treat.
So it's very difficult for me to give advice on a specific patient. But if we think about this theoretically, I can't speak for the liver aspect. One thing I could say is that specific liver diseases make you unable to absorb specific types of vitamins and nutrients, for example. And what this sounds like, it sounds like the specific enzymes that they need, meaning the exocrine function, seems to be compromised. So it seems like in the case of this 4-year-old little boy or girl, they're having trouble making the specific enzymes to be able to digest the fats in the foods that they are eating. And that can give them diarrhea and malabsorption. In cases where there's findings that is consistent with pancreatic insufficiency, such as the fecal elastase or the pancreatic function is abnormal, we do give pancreatic enzymes. And instead of your body making enzymes, you get to take the enzymes with food and that digests that for you, and then those symptoms improve. So in this case, if I'm reading the question correctly, it seems like there's pancreatic insufficiency, for which I would give pancreatic enzymes. But the liver being hard and the liver enzymes being elevated definitely needs more interrogation, investigation by a hepatologist.
From Mira, I have several stomach cramping. I've had severe stomach cramping, for up to 8 hours a day. My GI doc recommended an antispasmodic, but my pharmacist advised that I don't use it. What is your professional opinion on taking the antispasmodic?
Mm-hmm. So the antispasmodics that we're talking about, it's like hyoscyamin or Newlev. And, I do give that medication to my patients who have cramps and spasms. What I tell them is that you don't want to use a lot of it. For example, you can use it as needed. It goes under the tongue. It's sublingual at the time when you get the pain and hopefully stop it from becoming worse. but I wouldn't use it 5-6 times a day, because the thing is, it's an anticholinergic, meaning that it tends to stop your ability to pee, or it can cause other types of side effects and problems and will make you more constipated. So you don't want to use too much of it because you can have the side effects of that medication. So I suspect, barring that I don't know what other medications the person who asked the question is taking, that the concern of the pharmacist here is the side effect profile of the antispasmodics.
Great. I think we have time for maybe a couple more questions. What high nutrition drinks would you recommend for mitochondrial disease patients, MC patients with malabsorption and weight loss? You mentioned Cape Farm and Boost. Are there others?
Oh yes, there's actually so many different types of nutritional supplementations, and it just depends on what their underlying problem is. I guess the way I would describe some of the supplements are, depending on the age for the patient, the supplements are different. Depending on the protein in it, right? So we have supplements that are full protein, supplements that are hydrolyzed, meaning that they're partially divided protein, and then supplements that are fully divided, where the protein is divided into little tiny amino acids. And in patients where they do have significant nausea or inability to tolerate feeds, or have significant intolerances or allergies, I like to use a formula that it has little tiny amino acids in them. So it's either hydrolyzed or amino acid based. Patients who don't tolerate a lot of volume, I like to concentrate the formula and get more bigger buck for, I forget the phrase, but get more for our buck, meaning that instead of 1.0, where it's 30 calories per ounce, it's 1.5, like Boost Kids Essentials or Boost Plus, and that's 45 calories per ounce. So it just depends on the patient. And this is, I think, highlights the importance of making sure that you are working with a gastroenterologist or a provider that has a dietitian who works very close with them to be able to help you with this. And some of them have higher sugar content, some of them don't have a high protein, or they're just carbohydrates. So it really is a matter of, are we trying to meet hydration, nutrition? Or do we have pancreatic insufficiency? How much fat are we getting? So all of those things take into account.
I'm going to just take a couple more. Thank you for your time. Our son had COVID in September. Since then, he barely eats by mouth and is on increased G-tube feeds. His already complex GI symptoms are not compounded. Are you seeing a lot of post-COVID symptoms in patients? And if so, are you seeing them resolve over time?
We are seeing a lot of the gastrointestinal manifestations of COVID. One of the most common ones and drastic ones is the loss of taste and smell, and that is definitely preventing patients from being able to eat or drink. We've had patients who've otherwise able to eat and drink without difficulty become gastrostomy tube dependent because of it. Other patients, for example, have, I think of COVID like similar to any other virus. If you already have a predisposition wherein you're in a fragile state, a viral infection, a bacterial infection is a hit, and it takes you from this baseline to this baseline. And we are seeing that with COVID, as we would see with the flu or any other viral infections. With regards to improvement over time, it's way too early to tell. It's only been a couple of years, and we just don't know. And we haven't done the study specifically in mitochondrial kids to be able to tell if we're seeing improvements. But overall, I think about it in terms of that some of our kids have shown improvements and some of them don't. But in terms of giving you numbers, it would be very difficult to tell.
And one last one. How frequently do you find rapid gastric emptying with mitochondrial disease?
Not very frequently, actually. But that could be because we're not testing it too, right? We just assume that somebody has nausea and vomiting, for example, and then we advance the feeds from G to GJ. In my clinical practice, I don't find it very often. I have a few patients with it, more of the delay than the rapid. But I always like to get a good gastric emptying study to be able to know that I'm treating my patients adequately.
Right. Wonderful. Again, everybody, I apologize. We are out of time. There are still many unanswered questions that you had submitted. We have them. We will get answers for you, and we will get that information back to you. And I thank you, Dr. Lucene, for being with us tonight to talk about this very important issue that a lot of people are interested in. And I just want to thank everybody for joining us tonight, and to remind you that we do have the Maze webcast that will talk about Mito basics and our symposium primer that is set for May 18th at 7 p.m. Eastern. Thank you all.
Thank you so much for the invitation. It was a pleasure.